The International Childbirth Initiative presents Perinatal Palliative Care, Part 2. For Part 1, please see link in the description. Nailu, thank you so much for that presentation. I hope everyone enjoyed it. We're starting to get, we had some comments in the chat. Just to let everyone know, I will send out the slides afterwards. And we have a few questions that were actually sent in before the session. So I wanted to go through those questions, but please go ahead and put your questions and comments into the chat, and we will get to them, and you can unmute and share your questions. But I wanted to start with a question that came in advance. Actually, wait, sorry, let me switch to this other question. So you mentioned, and this question was sent in before, um, about the support that continues after they've been discharged from the hospital. So do you have, Nailu, some general recommendations for if they don't have protocols in place already, how would you recommend that teams try to support parents once they have left the hospital?
Yes, I really thanks for the question because this is something that I do. Um, Me particularly, I developed a protocol at my hospital that we get in touch with the families 4 weeks after death. This number, this magical 4 weeks number, this is not an absolute. We must try to be present, but we must give them a time to digest what happened and also to be in touch with people around them because usually they are so overwhelmed about what happened that they didn't even have time to think. So we must give them time to think and to have questions because it takes them a while to try to understand exactly what happens, and a lot of times uh, they come up with questions regarding the care, regarding what happened, what if scenarios, like, oh, what could have changed if this happened, or even about like the diagnosis itself or the next steps. So we must be present in this time when they have questions on their minds. And also, we must be present for them to feel like they were not forgotten because they have received so much care and attention during pregnancy, during labor, or during the immediate care while they were at the hospital or any other setting. And then they feel like they were abandoned. And when we are present, when we get in touch after this period of time, I guess it's also a way for us to say that you still matter, we are still here, and you can reach us. And also because uh, they will keep thinking about those doubts without anyone to reach out, and they may create different stories about it that will haunt them. And that's a for me that's a great opportunity to clarify things, and it's not unusual for them to blame themselves about a few things. Sometimes I reach the families and then the mother says, oh, I know it happened because I ate something during pregnancy, or some I don't know, some minor thing that happened during the admission. And sometimes it's very important for us to show that we are available and to clarify the things. And because it's not rare that we still had some exam happening in the background and we did not have the results yet, and they were keep thinking about it. And then we say, no, no, that exam, they came negative. That's not what happened. And usually what I try to do, it's I revisit it all. I studied it all over again, try to put it in a time frame to tell the full story and for us to understand. And sometimes even for genetic counseling, if we must refer them for further evaluation, if we're talking about a malformation scenario. So I usually get in touch um, around 4 weeks after. I think so far it's been helpful. And whenever I'm at the hospital and I'm doing this job, because neonatal death it's a rare thing, right? It's not like an adult ICU. I don't think it will be so feasible for them, but it is for us. And whenever I'm doing that, people always think that it's such a sad work that I'm doing. People are like, "Oh, you're reaching out these families," but that's quite the opposite. Usually, people feel very happy uh, that we are getting in touch, that I still remember that they still matter. So those are not sad calls. I usually call them, but those are an opportunity. You should schedule a time in your agenda because it takes a while. But I think that's a very, very important thing. It's not something that requires technology or a lot of resources, but I think that's very important thing to do. And also, thanks for the opportunity to be talking about it.
No, Nailu, thank you so much. I just think I think they're so lucky to have you as their doctor, honestly, in
Oh,
these
thank you.
cases, you know. I'm just going to share this comment from Beatrice that the presentation was very clear, and she said, "Thank you for recognizing us doulas as part of the team effort, valuable team effort. I was impressed by the care and respect shown in this approach." She's a birth and end-of-life doula from Italy and part of the European Doula Network. So, thank you for Beatrice for that comment. No, I think it's really fantastic the approach that you have, Nailu. Um,
Yeah.
so we
But talking about doulas, I've been talking about communication and to be in touch with families, and who else will perform it better than doulas? Like they uh I saw that one of the questions was, oh, what doulas could do in this scenario. But I've been talking about communication and care. So uh, probably most of the work. uh, Me as a NICU physician, I even though I try my best and I schedule meetings, the amount of time I spend at the bedside, or I spend with the parents, it's it's uncomparable, right? So doulas have a major part of it, because if I'm talking about, I must recognize and I must pay attention to the family values. They are the ones who knows it the most, and they are the ones that can advocate for the families, because we know that there is a distance, almost a technical distance, between the families and the medical team. And that's such an important bridge, because they can talk to both sides. They have the technical knowledge, but also they can reach, they are so close to the families. Even when we talk about, I guess someone asked if one of the parents or someone from the family doesn't want the life supporting treatment to be removed or something.
Yes.
And of course, that's such a tricky scenario. If we're talking about parents, they
Mm,
must be on the same page. And I guess one of the important things for us to do is try to translate feelings into what we truly want as an action. And sometimes they don't want it because it's hard for us to translate the feeling that I love my baby and to understand as removing the support as part of it. It's hard for us to make it this connection, and someone who understands them and may help them to translate this feeling into action would be the ones that are at the bedside and know them way more
Hmm.
than the medical team. And but when we are talking about people that are not the parents,
Hmm.
I I will say a phrase that might sound harsh. I swear it is not. But those decisions, they are not a democracy. People don't have votes, right? It's not that we're gathering everyone and voting about what we should do with the baby. We have parents, and they are the ones that they will have the decision. And I will be very happy if everyone from the family is in the same page. I would love that. But sometimes there is a member of the family who is not, and we'll talk to them and we'll explain them everything that is happening in the best possible way because this is an important person. But sometimes they will keep with another vision, and that's unfortunately something that happens. But we must have this core people, this core important people, those must be aligned.
Hmm.
And those are the important person that we must take into account. But
Yeah.
even though I'm from a low, I'm from Brazil, that I'm not from a rich place. And I guess most of the things I talked about, those are not expensive, but those are just something that we don't usually think about. And that's, I guess this presentation is about to think about these things that will will matter so much and doesn't require money, equipment, technology. It requires us to be aware and to be prepared for these scenarios.
So yeah, Nailu, thank you so much. So I think that that's a good point is so for the team, the medical teams that are having trouble with getting the parents to make a decision around ending the life support or taking out the IVs to try to orient from that emotional perspective of like the emotional goal and finding maybe other things, which I think you suggested in the presentation as well, of like other things that they can hold on to, like mementos and things like that to help them make progress and move towards a conclusion where they feel like they've been able to participate and that that they're able to process. Um, there is another question that came in, and it's something that you and I think, talked about in advance as well. Someone asked about the decision to deciding whether it's safe to do a vaginal delivery for certain diagnoses. And I mean, I think this is maybe hard to generalize, but perhaps you could think of some examples of
Yeah,
diagnoses where like the conversation moves to whether a cesarean would be an option and or whether a vaginal delivery, should be considered. Could you talk about that a little bit?
yeah, sure. Um, Medically speaking, there are not a lot of situations where a C-section is mandatory. And I know that a lot of people made like this direct connection between any anomaly, C-section. That's not the case. Even if we talk about heart disease, there are a few scenarios, especially involving arrhythmia, where the stress and the labor itself could potentially make it worse. We can talk about scenarios where a dystocia might happen, like if the head circumference is too big, for instance, usually bigger than 36 centimeters. The risk of a dystocia it's gigantic, so it would be bad for both the baby and the mom, and even some limb or um, osteogenesis imperfecta. Of course, we don't want this baby to be pushed because their bones are so fragile. But what I see And we should not take this reason for granted. But what I see is most of the time the C-sections are scheduled because the team should be prepared. It's a facility where they don't have a 24/7 support for some specific conditions, and then they schedule a C-section, so then a whole team, a specialized team, will be available at that moment. And we can, you guys know even more than me about the risks and benefits of a C-section, and that's something that we're trying to avoid. But sometimes it's necessary. Sometimes the baby will require some, possibly they may require some fast intervention, and then we won't have an available team for that if the baby is born during weekends or in the middle of the night or something like that. And then people end up scheduling that. But we do have proper literature for that. Most of the conditions, if you search on PubMed or something, that there will be work available on it. So extreme prematurity, it's not good for the baby. It will increase the risk of brain hemorrhage. So there are a few scenarios that we know for sure that we should do a C-section, but those are the minority. We should not consider that, oh, if anything is wrong with the baby, we should not proceed with a normal labor, because that's not the case. But I know that's usually what happens.
Yeah. Um, Thank you so much, Nailu. I mean, I'm thinking that maybe we could try to find some additional resources for people if there are follow-up questions about this, because it is complex, but it's really great to have your perspective. I think especially in Brazil, where there is a real tendency to go to C-section. I mean, it's
Yeah.
good that you are there as a neonatologist, counseling for the reasons that they don't necessarily have to do that. Does anyone want to unmute and ask a question or make a comment? You can put your hand up or you can just go ahead and unmute yourself. I'm just scrolling through the comments again. Everyone's so quiet.
Maybe I'm talking too much.
No, I don't think so.
No, the presentation was brilliant.
Oh, thank you, Maura. Go ahead. You can speak.
No, I was saying the presentation was brilliant. That is why there isn't so many questions, because it was very clear, and the content was very much easy to really follow and understand and digest.
Oh, good. Wonderful.
You're very kind. Thank you so much. And thank you all for your interest. Part of my job is like spreading the word. I just want people to be aware of it, and I want everybody to be able to receive uh, a good care. So I'm so happy to be here. Thank you for inviting me.
Nailu, oh, sorry, go ahead.
It's only Di Garland. Hello there. Sorry, I was a few minutes late, so I hope I didn't miss that. I was just thinking about engaging with student midwives. I can remember as a student, I was almost shielded from any neonatal potential or actual poor outcome, and almost to the point of qualifying. And then suddenly you can guess what happened. I qualified and was put in that position. Now, we certainly do in the UK try and engage both in the academic world, but clinical. Clinical is very difficult for obvious confidentiality, privacy, everything we can imagine, and you've very kindly shared. But I just wondered if you have any thoughts, and particularly for medics, because they must be maybe even more remote and don't have those opportunities either to learn the skills that you've been sharing with us. So any thoughts will be wonderful.
I'm not sure if I completely got your question.
I think maybe I could try to restate a little bit. So I think, Diane, if I understood, uh, I think the first point was that the student midwives don't get a lot of exposure to the complications because they don't have the experience yet. And so maybe there's a concern about having them be involved. So they don't have learning opportunities in order to learn these skills. So is that, so I guess the question is that something that do you work with students or do you have a program for them to, so that's a challenge is if they don't get to learn it while they're students and then they just get thrown into the field and then eventually they have one of these cases before they've had a chance to build their skills. And same thing for medics where they might only get the opportunity when they're actually facing the issue. And I think that's been an issue, I think, in the UK where there's been that some of those cases happening where sort of unprepared paramedics are arrive to a home birth with a particularly bad complication.
Got it. Thank you.
Mhm.
There is a paper, I will share with you a lot of papers I do have been collecting throughout the years. But there is a paper on bioethics that I find it brilliant because they say that whenever we are in the ICU with adults and something happens, um, the overall feeling is that, oh, we were not able to save this person. And in neonatal care, um, we are so blamed because if the baby survives with some morbidity, people will say, "Oh, look what they are doing. They are making those babies survive with a disability." And if the baby doesn't survive, we are also blamed. So it's expected from us to be perfect and also to uh, to don't live with any type of bad outcomes. So they are hidden because they are seen as failures of the system and failures of the team. And I guess it happens everywhere. It's part of, I guess, the culture, even the medical culture. And I think that I ended up working as a data analyst because if you remembered like how Michelle was introducing me, I I know it probably sounded very confusing. Like she works with perinatal palliative care, neonatologist, and she's a data analyst. That doesn't make sense. But it all started because I was hungry for information, and I don't think we have it. And I do teach residents, and I do teach medical students, and I talk about these matters. And I think that now in medical school, at least, it's something that's being talked about more often. It wasn't at all when I was in grad school. And I think that part of it is that um, our outcomes, it is seen with a different lenses, with a different perspective than other outcomes from other specialties. And I think it is important. And also, when I was talking about viability, I said, oh, we should know about the viability where we are in our workplace. And I don't think most of you know. I didn't also. That was one of the first things, one of the first data that I started to collect to understand the outcomes in my own institution. How am I supposed to make a proper plan if I don't know uh, the viability of my institution? I don't know what happens to those 25 weeks. What happens to the 26 weeks? What happens to the 27 weeks? How am I supposed to give a proper counseling? How am I supposed to create a proper plan if I'm not aware of it? And I'm now developing one of my projects now is to develop a dashboard with the viability all over Brazil. It's an individual work that I'm doing by myself because I want to spread this information. And some people even go beyond and say that this should be like public available because the moms should be able to choose a hospital based on it. If I'm in a big risk of a preterm labor, so then I can reach a hospital where I know the outcome is better. But we can talk about the ethics around it for 20 hours. But that, yeah, I guess it's something that we don't talk about, and that we should talk about it, and we should gather data, and we should be aware of it. I hope it answered the question.
So, um, you're almost suggesting to me, Nailu, that we could have a whole second webinar digging into, no, but really, because what you had mentioned as well about the predictive, difference between who is performing the, the assessments, and that snapshot from Brazil, and the importance for people to look at some of the data to understand when they're trying to make a diagnosis, how, accurate is the information and what is the likelihood of a correct prediction. Um, Especially in counseling the families, like that's a whole chunk of work in and of itself that is very important. I just wanted to ask you, expand. So you mentioned that you do work with, you do you teach midwives? Like, are there sessions to actually educate midwives about some of this, or is that not something that you're doing?
No, me particularly, no. I'm only connected to the medical school,
Hmm.
and uh, but our webinars, they are for everyone. But my one-on-one conversations, they are mostly with the medical students.
Okay. Okay. Does anyone else have questions or comments? I mean, you did cover so much material and you covered it very
Yeah.
clearly. And I know, Nailu, you were concerned because, of course, English is not your first language, so you were speaking
Yes.
slowly. But I think actually in this case, it was actually very helpful because you spoke so clearly. I think also hopefully for the people who are watching with the subtitles, I think the subtitles will go at a nice pace for them to absorb the information. So the recording of the lecture is already on YouTube, and I've put the link into the chat, and it does have subtitles in Spanish or in French. And we will
What about
also,
Portuguese?
I'm
My main
sorry,
language. You're
we should,
ignoring my main language.
we'll have you recorded in Portuguese. We'll get there. I actually got I was actually trying to do Japanese subtitles, and I had hit my limit for how many translations I could do what the program I was using right before this. So we will do Portuguese. Um, and we will add the discussion as well because I think there was a very rich discussion. Oh, T Luna, do you want to unmute and say something? You were saying you would like more Brazilian birth connections. Could you elaborate on that? I don't know if you're at a place where you
Oh,
can.
yes. Good day, everyone. Yeah, no, I was just saying I would like more Brazilian connections. I'm working on this like language project for birth workers, midwives, doulas to have like compassionate bedside manner as they're like traveling or doing things throughout the world. And so that's why I was thinking about having Portuguese as one of the languages, specifically Brazilian Portuguese.
I'll be happy to help if that's what you need. I've done some translation work for the ICI also, but I also like to frame that it's the Brazilian Portuguese. It's not exactly the same as the
Exactly.
one from
Yes.
Portugal. So I'm making my case.
Oh, I use
But
Brazilian Portuguese, so no problem. I've only been to Brazil, so that's okay.
oh, have you been to Brazil?
I have, yes, yes. Uh-huh. And I live in Ghana now, so I be around. That's why.
Great.
I definitely learned that with bom dia and bom dia. So yes.
Yes, yes. I say bom dia. I'm do the GGG, the Brazilian GGG.
I'm just adding because Diane is mentioning that ICM is in Lisbon, which is true. The conference coming up in a month. We will have an ICI event on June 12th. So if you're going to be there, if you're going to be there in time, but we'll also have an ICI workshop at the ICM Congress on the Wednesday, June 17th. So please, oh, good. Send me an email. I'm just going to put my email in the chat. Please email me and I'll make sure you get the details of our events. And Luna's also asking if people are going to Scotland for the Mercy in Action event, which is right before that. Nailu, thank you so much. This was really fantastic. I think it was, everyone seems really thrilled about the subject. I know a lot of people couldn't join live, so we will be sharing the recording. I'm sure a lot of people are going to watch the recording as well. And we're also grateful not just for this, but for all of your work with ICI, also helping work with our data. It's been fantastic having you with us, and we hopefully are not going to let go of you, and you're going to stay in touch
No, I'll
when
be
you get back
around.
to Brazil.
Yes, I'll be back in Brazil shortly. And I just sent my email on the chat if anyone needs to reach
Okay.
out to talk a bit. While I was here, I talked to a bunch of people about perinatal palliative care, and I'm